mode, you can see the barcode sign and the absent lung pulsation. If you suspect that the patient has massive chest trauma and cardiac tamponading, in the sub-xiphoid view, you can put your probe and see any coil collection around the heart. If the right ventricle is collapsing during diastole, which is called the trampoline sign, so this is a sign of cardiac tamponading. You have to use pericardiocentesis, and if the patient is arrested, if it is massive, you can do open or resuscitative thoracotomy. Okay, either if the patient is arrested, I can use the focus. Why I use the focus? Because the focus is changing the algorithm, but don't interrupt the CPR. So in 10 seconds, while you assessing the pulsation of your patient, start to put the probe in the subxiphoid, next time in apical, next time in mid-clavicular, and next time in the costophrenic angle of your patient to check for the reversible causes. And also you can see what is known as pseudo-pulseless electrical activity. So what is pseudo-pulseless electrical activity? Pseudo-pulseless electrical activity that you can see a patient who is arrested with organized rhythm, but you can see fine cardiac motion. This fine cardiac motion in the image in the left of the screen, you can see that there is some contractility, but not enough to generate a pulse in your patient. So this is pseudo-pulseless electrical activity, has a good prognosis. You have to work and find the reversible causes and be very aggressive in resuscitation because your patient has a good prognosis. But on the right side of the screen, the video, you can see a heart which is called the standstill heart. In this heart, there is no cardiac motion, and this patient has low prognosis in the resuscitation. Okay, also, sometimes you find that your patient is asystole on the monitor, but if you look to the video, to the right side of the monitor, you can see that there is some fine fibrillation. And the video on the left side of the screen, you can see that the heart is standstill. So, in the monitor, I can see that there is asystole, but in the ultrasound, I can see that the heart has fine ventricular fibrillation. So, I will change the algorithm from non-shockable algorithm to the shockable algorithm. I will give shock because this is a fine VF that the monitor can't detect this fine VF, but the ultrasound can do this. So the focus has a great role in traumatic cardiac arrest. So when to decide to stop the resuscitation, if there is no cardiac motion in the focus, after addressing hot causes and after 10 minutes of resuscitation, you can consider the termination in your patient of traumatic cardiac arrest. If you are working in the pediatric, you have the same concept in traumatic cardiac arrest, but also put into consideration the differences in doses in joules between the pediatric and the adult according to the guidelines of the ERC or the American Heart Association. So, to summarize, please remember that traumatic cardiac arrest is not like medical cardiac arrest. You have to focus on the reversible causes with the mnemonic HOT. Please use the focus ultrasound as early as possible to find these reversible causes. If the patient is arrested, also use the focus to know if there is fine VF or pseudo-pulseless electrical activity. Hemorrhage control saves life, and prolonged CPR is rarely effective. Thank you very much, and I am ready if there is any question.
Professor Halef, thank you very much. I forgot to say, Professor is a member of Atudersona School also. Again, we would like to thank Professor for this excellent presentation. Are there any questions or comments from audience to Professor? Başaracağım. Professor, I think Professor Caner will ask a question or comment.
No question.
Yes,
Thank you very much,
yeah,
Dr.
yes.
Thank you very much. But Dr. Han, I'm not member of Solar School. He's manager of Solar School with us.
Sorry.
Thank you very much. And it's a big honor to hear from you. It's a very nice presentation. I want this only. Thank you very much. I can't be waiting you for the next time face to face. I hope.
Inshallah.
Inshallah.
Thank you, and see you also in Saudi Arabia, Dr. Bashar, inshallah. Thank you very much for all of you. I'm really happy to be with you every time, either online or physically. Thank you very much.
Thank you very much. Herkese tekrar merhabalar. Ben Kocaeli Hastanesi Avcı Tıp Kliniğinden Doktor Melek Yıldız, Avcı Tıp uzmanıyım. İkinci Uluslararası Travma Kongremize hepiniz tekrar hoş geldiniz. Kongremizin bu ilk panelinin moderasyonunu değerli hocamız Sayın Doçent Doktor Demet Acar birlikte yapmaktan ve böyle değerli bir kongreye ev sahipliği yapan tarafta olmaktan büyük mutluluk duyuyorum. Şimdi sıradaki konuşmacımıza geçiyoruz. Kendisi Özbekistan'dan katılıyor. Orta Asya Üniversitesi'nden Profesör Hikmet Ahmarov. Bizlere travma ilişkili koagülopatiden bahsedecek. Now, with your kind permission, I would like to switch English to introduce our speaker. Professor, welcome. You are hearing me well?
Hello, yes. Am I audible?
Yes. First of all, thank you very much for your participation and for the valuable contribution you will make to our Congress. Today you will be speaking to us about trauma-induced coagulopathy. If you are ready, you may begin your presentation. Just a gentle reminder, you have 15 minutes. Professor, floor is yours.
Thank you very much. It's really my pleasure. And Dr. Bashar and all audience, it's my great honor to present this more information. So today's topic is a trauma-induced coagulopathy. I have to say that nothing to declare. Okay, yes, it works. So, as you know, the severe trauma with ISS or over 16 can lead to the acute traumatic coagulopathy by activation of the protein C and the adrenal glycocalyx disruption, consumption of the fibrinogen, and the platelet dysfunction. So these are several basic stats about trauma-induced coagulopathy that presents in almost 1/3 of patients with a severe concomitant injury and almost always accompanies severe and extremely severe acute blood loss upon the admission of the associated with a very poor outcomes, up to 14% of all deaths, and increased mortality even in 5 times. And main cause of death before age of the 40, so is a trauma due to the trauma and the coagulopathy and the bleeding, of course. Requires coordinated treatment based on the damage control resuscitation and great need for the transfusion. Of course, this kind of patient, they have to be cured long duration in ICU. There is support and high probability of multiple organ failure. All this factor has been described by Professor Karim Brohi and his colleagues in June 2003 in that so-called trauma-induced coagulopathy syndrome. And it worsens outcomes in casualties with uncontrolled hemorrhage. These are several factors as hypothermia, large volume crystalloid resuscitation, the platelet-inhibiting drugs. Of course, the shock and the blood loss lead to the acidosis with a protracted scene times over 2 hours and protracted pre-hospital time over 2 hours too. Severe bleeding in trauma diminishes oxygen delivery and may lead to the hypothermia. This, in turn, it can halt the coagulation cascade, preventing the blood from the clotting. In the absence of the blood-bound oxygen and nutrients, so it's like a hyperperfusion, the body cells burn glucose, as you know, anaerobically for energy, and causing the release of the lactic acid, ketone bodies, and other acidic compounds into the bloodstream, which lower the blood's pH and leading to the metabolic acidosis. So it's well known the pathogenesis. Such an increase acidity or damages the tissues and organs of the body and can reduce myocardial performance, further reducing the oxygen delivery. So, as you can see here, this is a pathogenesis of the trauma-induced coagulopathy with that internal factors as a hyperperfusion, blinded tissue damage, and external factors as hemodilution, hypothermia, acidosis, anemia, and electrolyte imbalance. So, pre-existing conditions as age, genetics, and as other comorbidities or medicines, they can also make a much more severe outcome. Combination of tissue trauma and systemic hyperperfusion cause global underpopulation and hyperfibrinolysis. And of course, endothelial activation of the protein C is a central mechanism, and trauma-related factors, and also some kind of iatrogene. So here is the scheme of the coagulopathy. As I said, the pre-existing conditions, they can make a shock much more severe, worsening the hyperperfusion, which lead to the systemic endotheliopathy. So there are so-called trauma-associated coagulopathy and trauma-induced coagulopathy. So trauma-associated coagulopathy is caused by multiple factors and includes trauma-inducing coagulopathy, which is caused by trauma itself. These pathophysiological mechanisms are the characteristics of the DIC with the fibrinolytic phenotype. Also, there is the pre-hospital care phase, so you can see it here, the point of the trauma, it can be the blunt or penetrative trauma, emergency medical attendance, so which can have two ways, so it's a coagulopathy identified as a norm, and it has the FPP and platelet administration, or here can be the standard resuscitation. So the pre-hospital care phase for the treatment and control the critical and trauma-related bleeding consists of the controlling of the bleeding. Of course, we have to close the hole, the manual compression and compression bandage, some wound packing, tourniquet, pelvic binder tamponade with, for example, nasal tamponade, restrictive volume therapy as a permissive hypertension. In trauma brain injuries, you know that BP systolic should not be over 90 millimeters, with a median for 60 millimeters. In trauma brain injuries, no more than 80. Volume replacement using only crystalloids. May use some vasopressors. Of course, if the patient is in shock, the tranexamic acid 1 gram intravenous as a bolus. These are European guideline recommendation. Also, shock room phase for treatment and control consists of the diagnostic evaluation, the clotting diagnostic standard test, blood gas analysis, of course. We may see the base deficit, lactate value, and we have to assess the pH value, of course. We need the imaging that was the fast ultrasound and computer tomography. Controlling the bleed is a crucial thing. You have to do all these damage control procedures, angiotensin stabilization, of course, Rebo, as my previous speaker said. Clotting stabilization consists of the tranexamic acid by the recommendation, targeted administration of the clotting stabilization factors, fibrinogen concentrate, optimization of the overall conditions for coagulations. And of course, transfusion therapy. In massive transfusion, fresh frozen plasma with RBC at least 1:2 ratio. FFP administration in platelets or platelets over the 1.5 or normal. And platelet administration with aim should be the aim of the 50 in the So, how to assess the coagulopathy? Early recognition of the nature of the clotting defect has been acknowledged as increasingly important to guide the replacement of the clotting factors alongside the blood volume maintenance and red cell replacement. But there are no validated diagnostic methods to guide effectively therapy. Usually, group of the tests are used, so inactivated partial thromboplasm and full blood count. full blood count. Traditional measures of clotting, as the platelet count, the bleeding time, prothrombin time, have some limitations in the context of managing trauma. So, the estimated average coagulation parameters in trauma are here. So we have to see the procoagulants and anticoagulants. Of course, you can see here in the trauma-induced coagulopathy, they have a slightly different. The platelet biology can also monitor here and hemostatic measures. So the latest studies recommend to use a viscoelastic testing such as a thromboelastometry. Thromboelastometry enables a point-of-care measurement using all blood samples of the initiation and progress of coagulation, as well as a finite fluid range, and analyzes the dynamic of the clot formation. Here we can see the test to check the extrinsic, the clotting system with a sample activation by adding tissue thromboplastin. So it's called tissue factor, and then the assessment of the clotting factors is 1, 2, 5, 7, 10, so platelet function, and fibrinolysis. The sample activation as an external test is addition of the cytoholazine T for the purpose of blocking the platelet activation. Enables the assessment of the fibrin polymerization and fibrinolysis. The optimal way of the management is so-called damage control resuscitation, which includes the damage control surgery, of course, so we shouldn't waste any time. Restrict a balanced resuscitation with a controlled hypotension, no more than 90 and 80 in TBI patients, and restrictive tactics of fluid administration, hemostatic resuscitation, and management of acidosis, hypothermia, and hypocalcemia, which are the crucial things here. So, these are the guidelines recommendations. So, the ATLS subcommittee, American College of the Surgeons Committee on Trauma, and International ATLS Working Group recommends here the systolic blood pressure 80-90, as I said, mean arterial pressure not lower than 80, and the volume of the infusion support until the possibility of the blood transfusion appears up to 1 liter normal. And also, you can see the recommendation of the tranexamic acid to be administered as early as possible to the trauma patient who is bleeding or at risk of the significant hemorrhage, and loading dose of the 1 gram infusion over 10 minutes, followed by intravenous infusion of the 1 gram over the next 8 hours. This is for grade 1A. And also the recommendation that tranexamic acid to be administered in the bleeding trauma patient within 3 hours after the injury. This is a grade 1B. And also there is a suggestion that the protocol for the management of the bleeding patient consider administration of the first dose of the tranexamic acid en route to the hospital. This is the recommendation grade 2C. So, acidosis, you know that some factors which provide the acidosis is decreasing myocardial contractility, vasodilatation, decreasing the hepatic and renal blood flow, ventricular premature beats, and reduces the effectiveness of the coagulation factors and reduces the platelets adhesion and aggregation. So, you know, the hypothermia always can be occurred in 2/3, in over 60% of the severe trauma, playing in the pathogenesis of hemorrhagic shock in trauma, consequence of the resuscitation of the infusion therapy, so we shouldn't use the room temperature fluids, worsens the coagulation and worsen the forecast. Hypocalcemia, you know, the coagulation also affected by the hypocalcemia, platelet adhesion, stabilization of the fibrin platelets in thrombosis formation, myocardial contractility, and contractility of smooth muscles. So, hemostatic resuscitation in massive blood transfusion, so we have to do the over 10 units of packed red blood cells within the 24 hours. All transfusion, the over 20 units of the purified red blood cells within the 24 hours. Indication should be as follows: for the severe trauma, when we see the free liquid on the fast, in the mental disorders, when I have a heartbeat rate over 120 acidosis, coagulopathy, anemia, and hypothermia. The protocol consists of the several packages. For instance, it can be package 1 for doses of blood from the one group, or universal, so it's a negative one. All this within the inpatient with a continuing bleeding can be used. Package 2 for doses of the single group blood, plus 4 doses of fresh frozen plasma and platelets excretion. So here I can provide some data from prospective studies from 2009. So the prospective study covers over 350 patients. 100 of them received the warm blood, fresh blood. 254 received the component therapy. So you can see within the 24-hour survival rate, 96% in the first group, in the fresh blood group, has survived, and only 88% in the component therapy. And within the months, survival rates were 95 and 82 respectively. Of course, fresh blood is the best replacement, but it's not allowed in many countries. So, fibrin again concentrate and pre-precipitate are also very good to use, and if the concentrate-based strategy is used, there is a recommendation with the fibrinogen concentrate or pre-precipitate is insignificant bleeding accompanied by the viscoelastic size of the functional fibrinogen deficit or plasma fibrinogen level less than 1.5 or 2 grams per liter. And of course, I'm using the F7, the 7th factor, NOVA7, so recommended activated coagulation factor 7. There is a suggestion that the off-label use of this recommended F7A to be considered only if major bleeding and traumatic coagulopathy persist despite all our attempts to control bleeding and best practice use of conventional hemostatic measures. This is a recommendation right to see. In that research, there is a further perspective, what we have to accent on, the place of the clotting factors in the protocol of massive blood transfusion, effect of the depth of the anesthesia in outcomes, so regional anesthesia can be a solution. Duration and depth of the permissible hypertension and assessment of the endothelial function in shock. The effectiveness of the use of antioxidants in the first hours of the injury, and as Dr. Haitan said, the rebound in the pre-hospital stage. Thank you very much. It was very brief overview. Hello.
We would like to thank our speaker for his volume presentation. Are there any questions or comments for our speaker from the audience? Please.
Thank you for I am glad to listen your listen this. I want to ask about tranexamic acid. How many hours after onset should tranexamic acid be started?
Thank you very much for this question. Yes. As the European guidelines recommendation, it should be 1 gram within, in the severe bleeding, it should be 1 gram within the first hour and 8 grams within the next 24 hours.
Just 1 hour, was it, right?
It should be bolus and basis. The bolus 1 gram, yes, 1 gram IV within the first hour, and in the next 24 hours, 8 grams, respectively.
One question. Yes, please.
Sorry.
First of all, thank you for your presentation. That was great. I'm 5th year med student. I'm here to develop my trauma area skills. I have a question. You mentioned that there is no validated method to diagnose trauma-induced coagulopathy at the moment. Do you have a practical algorithm that you use in daily practice based on the clinical findings before the lab test?
Yeah. Mhm. Thank you very much. Yes, there are several guidelines also and protocols. Of course, first, this is a clinical diagnosis, and I said that the assessment of the viscoelasticity of the blood looks very promising. And I think, yes, we can use this viscoelasticity test. Of course, when you have these three main things, this is a triad of the death in the trauma-induced coagulopathy, which is the, as and also have provided, is hypothermia, which can be occurred maybe in 60 or 70% of all huge major traumas. The trauma itself, metabolic acidosis, and coagulopathy. This is, this is a circle, and we have to manage anyhow to break this chain.
Thank you very much.
Thank you. Are there any questions? Yes.
First of all, thank you very much for your clear and valuable explanation today. My question is, after seeing all these steps in trauma management, what is the single most important thing you want us to remember?
Yes, actually my last slide, a bit some kind of take-home messages, so we have to think about this. Firstly, very simple steps in ABCD, you remember all of you, that E is to expose patient, but to cover him, in order not to provide the hypothermia. We have to avoid the hypothermia first. The hypocalcemia, also the crucial, as I said for the previous asking person, and this how to prevent this trauma triad of the death. We have to take care for the coagulopathy and the massive blood loss. Sometimes, we have the rebound effect from the massive blood transfusion, which also can occur in massive over the 8 units within 2 hours of the RBC from the several groups and from the several donors. And thinking about the new technologies as well as Rebo also, which can be also a solution even on the pre-hospital stage.
Okay, thank you very much.
Thank you. Are there any questions or comments? Professor Canlı.
Hikmet Bey, çok teşekkür ediyoruz. Ata yurduna selamlar. Size çok soru
Çok
var.
teşekkür ederim. Ben teşekkür ederim.
Size çok soru var. Sizi bütün takım bekliyor. Zeynep Hoca burada. Mehmet Hoca burada. Biz sizi Konya'ya da bekliyoruz. Antalya'ya da. Buhara'ya selamlar. Taşkent'e selamlar. Büyük hocalarımız var. Yanında Adil hocamız var. Türkiye'de travmada, cerrahide. Onda selamlarını çok teşekkür ederiz. Peki, görüşmek üzere. Çok teşekkürler.
Değerli sunum için hocamıza tekrar teşekkür ediyoruz. Sözü tekrar Demet hocama bırakıyorum. İkinci oturumumuz gene uluslararası online bağlantılarımızla olacak. Bu oturuma başkanlık etmek üzere Profesör Doktor Başar Cander hocamı ve acil uzmanımız Yasin Yıldız Bey'i sahneye davet etmek istiyorum. The next oturumdan önce isterseniz bir 5 dakika coffee break arası verelim. The next session will be international again, and the chair of this section, Professor Cander, and emergency specialist Yasin Yıldız.
We can start or we can wait. Not important. Up to your time. We can start or we can waiting for you because up to your time.
I was just testing, to see the length and everything.
I'm still in the clinic, but I would be happy to start. Whatever you want to start. Okay, we can start.
Thank you. Thank you.
We can start now. Yes.
Okay, Professor Bashar, do you hear me? Professor Bashar?
Yes, we can hear you.
You can hear me?
Yes. Can you open your camera? Can you open?
I will open the camera now.
Okay.
Okay, we can start. We can hear you.
Let's open the camera first.
Okay.
Can you see me now or not?
No. Why you don't?
Okay, now?
Göremiyoruz. Okay, open. Bir buldum. Şimdi Doktor Hasan.
Okay.
Hatırla daha önce bana.
Let's try again.
Biz oradan konuşup bekliyoruz.
But they don't see me. Not here. Okay.
Okay, Dr. Hassan, we can see you. Thank you very much.
You can see me, but can you see the slide?
Yes, of course. We can see slide and
Thank you
you.
very much.
Okay.
I cannot see you, but it's okay for me.
Bizi gör.
Good afternoon, everyone, and thank you, Professor Bashar, for the opportunity, and thanks for the organizing committee for, giving me the chance to present. I'm going to present on the management of a trauma in pregnancy, a multidisciplinary approach. Qatar experience. I have nothing to disclose regarding this presentation. The specific objective that I will discuss and highlight is, will highlight the prevalence, mechanism, physiological changes, diagnosis, and perioperative consideration and postoperative care. And of course, the multidisciplinary approach that we have. As the prevalence and the mechanism of injury for trauma patients during pregnancy, it is affecting to 7% of all the injuries complicate 1 in 12 pregnancy worldwide, but in Qatar actually 1 in 4 pregnancy is affected by trauma, associated with the 20% of maternal death in United States, and it is 1% in Doha. The physiological changes with the pregnancy, as brief as I might to explain it, we divide it into cardiovascular, hematological, and pulmonary, which is very important for trauma resuscitation. Cardiovascular mainly decrease the systemic vascular resistance, increase cardiac output, and arterial pressure. So these are very important to be taken into consideration when it comes to resuscitation. The second element is the hematological changes, which is impact on the plasma volume increase, and especially on the 30 and 40 weeks of pregnancy. It can be up to 50%. Also, red blood cell mass increase and physiological anemia is common in pregnancy, especially in the beginning of the pregnancy. And prothrombotic status is changed, and this can be associated with increased risk of coagulation and impact on coagulation on the injured female pregnant. The pulmonary changes mainly is FRC decreased by 20%, and therefore it is important during ventilation to be taken into consideration. Oxygen consumption increased by 20%, and these are very brief but very important physiological changes in pregnancy. The diagnostic strategy is mainly done with radiation in the term of ultrasound. And the main issues with the ultrasound and the main things that we need to concentrate about is determination of gestational age, demonstrating that the fetal heart rate and heart rate is detectable. For the mother, it's important to identify the placenta location and also the effect on the placenta, the assessment of the amniotic fluid volume, the fetal well-being, and detection of fetal also anemia based on the physiological changes, delineating also the possibility of fetal injury and confirmation of fetal demission or the change in the cervix length for the delivery of the mother. In terms of radiation with pregnancy or contrast, well, I think the guideline clearly stated that when there is a need for a CT scan, it should not be delayed because the risk of the radiation is minimum in comparison to the benefit for the mother and child, and therefore we have to weigh the benefit in terms of the risk. Perioperative consideration is divided, of course, into patient consideration, surgeon, and anesthetist. All have the concern regarding the independent risk of the anesthesia for the surgical intervention in the maternity trauma patient. And therefore, when we look at the anesthesia and the data, there is two conflicting data. The first one is Mays et al. For no change or increase in risk in terms of abortion in a pregnant female undergoing surgical intervention with anesthesia, whereas Dunker et al. Found that there is an increased risk for spontaneous abortion. And patients undergoing general anesthesia have 1.6 risk ratio in comparison to a patient going for a gynecological procedure, which is 2. The risk ratio is 2. And therefore, this is very important to balance, what is the risk in terms of, surgical intervention for the mother and the well-being for the baby. The concern about the fetus is at the complexity of the diagnosis as well as the management of the injured patient. We have to understand that also this is dependent on the age of the pregnancy. We know that a major long-term defect associated with delivery of gestation less than 20%, so 24 weeks of gestation is associated with 70% long-term defect for the delivery. Whereas above the age of 28, the risk dropped to 20%. In terms of survival for gestation, it's almost no survivor for anyone under the age of 23 weeks, and survivor goes up to 90% for gestation age above the 28. And that's need to be taken into consideration when it comes to trauma. So how we have actually multidisciplinary approach in Doha and how we do it in HMC. We divide them into a pre-hospital and hospital. And in the hospital, we have the trauma surgeon, neonatology, obstetric gynae, nursing care, radiology, and anesthesia. And over this period of time, we have a multidisciplinary team that started from the pre-hospital. Birth at hospital without experience is associated with a higher risk of maternity and neonatal associated, perinatal death, as well as double or triple the long-term handicap for the infant. And for that reason,
we have to have a clear guideline for the pre-hospital care and where the patient delivered to the hospital. So if the patient less than 23 weeks, the chance for survival is minimum, and therefore the patient can be taken to the closest hospital trauma center. Whereas a patient who has a major injury, we need to transfer him directly to a trauma unit within Hamad, and that's what we agree upon. And also the severity of injury and the gestation age should not actually stop the transfer the patient to a direct trauma center. For that reason, we established the ambulance service clinical practice guideline, which has a 3-step, but these steps clearly indicate we have the protocol for bypass to facilitate to bring the trauma injured female to the trauma center to deal with it within Hamad. The second element within HMC or the trauma resuscitation. And for that, we have the trauma surgeon will take care of the initial assessment and management of the mother and the fetus. The anesthetist should assist the patient in terms of assessing the need for operating theater, trauma resuscitation unit for delivery of the patient, and also will lead the anesthesia before the obstetric anesthetist come to assist and help with the trauma team. Then the obstetrician will be attending the critical elements for the patient who are injured within notification time to take the decision to deal with the baby, whether there is a need for the immediate delivery or delayed delivery, and whether it is a spontaneous vaginal or the need for cesarean section. The neonatologist will be attending with the trauma team as the progress of the resuscitation takes place. So usually within 30 minutes, they will be attending at the same time. The radiology will follow the hybrid operating room protocols and endovascular requirement activation protocol. Nurses, usually we activate the nurses in the maternity, so we will have nurses coming with the team to support the obstetrician as well as neonatologists. So over the years, we had our experience in managing blunt traumatic patient with a pregnancy. This is a retrospective study from 2013 to 2015. At that time, we had 95 pregnant patients. The majority, or the mean age, was 30 years plus or minus 5.6 years. And we had the range of the gestation between 5 weeks up to 37 weeks. They are a young group of patients. The majority of these patients have a lot of injury. Most of the injury is related to motor vehicle accident. We have only 6% of the patients had an assault from their partner or their husband or family members. They have a lot of injuries and mainly fracture injuries, and the injury severity score was 9, so it is not severe, but the rate goes from 1 to 34 ISS scores. In terms of characteristics of the pregnancy, very gravel, so the first pregnancy was present in 21 patients. Second pregnancy is in 28 patients. Third pregnancy was in 22 patients, and multi-gravidae is only 12 patients. The gestation age ranged between 24 plus or minus 8.7. And the gestation age and delivery is 35.4 weeks. We had also the delivery of patient or the premature patient happening on 13 of these patients. We had only 1% or one patient who had maternity death in terms of the outcome for the mothers. The neonatal, unfortunately, we had 2 fetal death and 2 neonatal death in the pool. We had a second follow-up study, which was published in February 2025, looking at the time from 2015 up to 2021. It is also an observation study, retrospective. We had 566 patients, and the age was similar. The mechanism of injury decreased in terms of motor vehicle accident from 70 to 60, and the distribution of fracture is almost the same. What we come about also a right kidney ball bleed from that area. So she was packed, the baby was delivered and taken by the neonatologist. She had 11 units of PAC RBC, 12 units of fresh frozen plasma, 12 units of platelet, and 6 units of cryoprecipitation in order to correct the ROTEM result. And she was receiving the treatment. This is the CT image after we finished the procedure, which showed that there is a blush in the center of the uterus, and the patient had also other injury, including fracture of the humerus. She was kept as a damage control in the TICU, and then in the TICU she started to bleed. Her hemoglobin dropped from 10 to 7, and the patient was taken to the angio suite. There we identified the bleeding coming from a large blush, and a coil embolization was done, and the patient second day was stabilized, the acidosis was corrected, and also hemoglobin was stable. And gradually she was done very well and actually extubated. The infant, on the other hand, also became actually, after the cesarean section, the Abu-Gar score was low, but improved gradually, and he was taken to neonatal intensive care and did quite well following that. So the process of activation did very well for both, despite the fact that we had both suffered cardiac arrest. The mother and the baby was in apneic when they start delivery. So the post-operative care, we monitor the patient according to the International Institute of Health of monitoring, which required for the mother and the fetus. So to conclude regarding this presentation and the utilization of the multidisciplinary team, trauma during pregnancy presents a complex, clinically challenging due to the physiological change of the pregnant, potential risk to both the mother and the fetus, and the need for coordinated care across a multidisciplinary team. And without establishing this ahead of time, agreeing on the protocols, we will have issues when it comes to the patient. So that's the first message. Second message is a multidisciplinary approach ensure optimal outcome by integrating the experience of a trauma surgeon, obstetrician, anesthetist, neonatologist, radiologist, and the nursing staff. And when they work as a team, usually the outcome is much greater of benefits for the mother and the infant. With that, I would like to thank you for the opportunity to present, and I would be happy to answer any question, Professor Bashar. Thank you.
Thank you very much for this great presentation, Dr. Hassan.
Thank you, sir,
Thank you.
for a grateful presentation. Are there any questions to our speaker from doctors? Yes.
We have a question for you, Dr. Hassan. Okay, please.
Go ahead. Yes.
Doctor, I don't really have a question, but your sure name caught my attention, and I want to thank you. It's an honor for me to see someone from the Gulf countries giving a lecture in the place where I study. My name is Islam, and I am from Saudi Arabia, and I'm a sixth year medical student. Warm regards to you, doctor.
Thank you very much. Thank you. I wish you all the best and all your colleagues in the medical school.
Thank you.
Yes, thank you very much. Another question? We have very good cooperation with Qatar, and they have very good trauma system. Level 1, we hear from Dr. Hassan a lot of wonderful case. I think in most of the system they can operate like Qatar trauma center. It's one of the best center in the world, I think, Qatar Trauma Center. Hamad Trauma Center. Thank you, Hassan, for your great effort. And any yes.
Professor Bashar, I think coming to your center and seeing also the workload is amazing. But we have to share knowledge and exchange of experience, and that's the main thing about having this network. I look forward always to visit your hospital, and we will be happy also to have some of the residents from your center to join us. Hopefully next year, we have 2 spots, and this is an open invitation for your candidate to send 2 names.
Yes, thank you very much. And we moved together with Qatar Emergency Medicine together, me and Dr. Hassan, the World Emergency Medicine Society. We moved together. Thank you very much, Doctor. I think from Turkey, a lot of residents about to come the Hamad Center for the observation, the cancer. Yes, thank you very much.
That's great. I look forward to it.
Yes. Any question? Okay, thank you, Dr. Hassan. Very good.
Thank you. Thank you very much.
Değerli hocalarımız, sayın katılımcıların konuklarımız. Sıradaki konuşmamızı yapacak isim Profesör Halit Atayar. Konusu travmatic brain injury. Bağlantı sağlanmakta görüşmeye geçeceğiz.
Hi, Dr. Halit. Welcome. Do you hear me?
Assalamu alaikum. How are you all? Thank you, Dr. Bashar. Thank you, Professor, for the invitation. I hope you enjoy my talk as much as you have enjoyed Dr. Hassan's.
Yes, of course. Last time is your presentation, one of the best presentation in the Congress. Thank you very much. I hope you can.
Thank you very much.
If you need, we can start your presentation.
Yes, I am ready.
Okay, please.
Okay. Thank you very much for the opportunity. So today we're going to talk about a topic that has some controversies. It's a traumatic brain injury. So I have no conflict of interest. This lecture is only academic and education. So I'm going to discuss with you 2 key factors that's really warrant consideration. I will repeat these 2 factors the whole lecture to make sure that it is well understood. Some critical consideration that we need to consider in the management, and the rationale about the CT brain and how we can decrease that. So according to the International Brain Injury Association, the brain injury is the leading cause of death in the worldwide. As you see, nearly half of the TBI patients, traumatic brain injury patients, related deaths occur within the initial 2 hours of the impact. So they found that it's a very common cause of death, especially in the young people. It is estimated that one traumatic brain injury every 3 minutes, with a variation of these severities. Fall is the greatest cause of these numbers. Motor vehicle accident is the big problem that we have in young adults. And this is economically costly. Why is that? Because you have a young, healthy heart, healthy kidneys, healthy liver. They go into ICU with the severe bad injuries, but they don't die. They live for a long time, but they are debilitated. So they cause too much, and this is why